Hello, my name is Jacqueline Stevens. I'm an assistant professor in the Department of Occupational Therapy and an affiliate faculty member in the Molecular, Cellular, and Integrative Neuroscience program at Colorado State University. As an occupational therapist and a researcher, a lot of my work and my clinical practice has been with folks with traumatic brain injury. So today I'm going to be presenting the topic of Introduction to Traumatic Brain Injury. In the presentation today, I will give a definition and descriptors of traumatic brain injury, which you'll see abbreviated as TBI. I will discuss the physiological and functional consequences of TBI. I'll talk about how TBI is typically classified using the Glasgow Coma Scale. I'll talk briefly about prevalence, risk, and causes of TBI, and then I'll end with a quick summary. By the end of today's presentation, you should be able to define TBI and describe potential consequences, describe how TBIs are classified by severity, identify prevalence and common causes of TBI. Without further ado, we'll go ahead and get started with the presentation. So what is a traumatic brain injury? What is a TBI? It's defined as physical injury to the brain tissue from an external force that can temporarily or permanently impact brain function. The external force is an important factor because it makes it distinct from non-traumatic or acquired brain injuries. Those include anoxic, where the brain doesn't get enough oxygen, vascular, such as blood flow disruptions, degenerative, where brain structures start to degrade due to illness or disease, or congenital issues, where perhaps with children, brain structures did not develop properly in utero. The consequences of traumatic and non-traumatic or acquired brain injuries do quite look similar. So despite the mechanism of injury, you might see that the people living with traumatic brain injuries or acquired brain injuries looked quite similar in a lot of factors, and we'll get into those factors in a few moments. So TBIs can be described in a number of ways. One of the ways that it's described is through intracranial hemorrhage. So this is a descriptor of where the injury occurred. So as you can see from the image that I have here, you've got skin and bone, and then you have the meninges. And so the descriptor here will tell you kind of a little more information about where the traumatic brain injury occurred. So if it's an extradural or epidural hematoma, that means there's a blood clot above the dura mater. These tend to be less severe injuries, and people tend to recover from them better than the ones following. The subdural hematoma indicates that the blood clot is below the dura mater. A subarachnoid hematoma indicates that the blood clot is below the arachnoid layer. And finally, an intracerebral hemorrhage indicates that there is bleeding within the brain. TBIs might also be described by what type of injury occurred. So here we have a description of a contusion or a laceration. Starting with laceration, these are tears in brain tissues caused by bone fragments from skull fractures. So if you have a certain type of injury where the skull does fracture, the broken bone pieces can actually damage the brain tissue. Otherwise, you have patterns of contusion. And so contusion can be thought of as another word for bruising. And bruising can happen as a coup, which is kind of indicated. If you can see the mouse here, it's quite faint. It's a white mouse on a white screen. But you can see that a coup bruising injury would happen where the impact happens at the front of the skull, and you also have the injury kind of right here. A counter coup indicates that as the brain hits a structure, the head and brain hit a structure up here, the injury happens at the back of the brain because the brain actually slams into the back of the skull from impact. You can also have a combination of these injuries. So you can have a type of TBI that is considered a coup, counter coup injury, where the brain is injured in both the front and back or side to side, depending on where the impact happened. So the coup indicates where the impact happened, and the counter coup is the opposing side. There are a number of physiological consequences of TBI, as you might imagine. So any individual brain structure or functionally connected structures, which are also called networks, can be compromised in traumatic brain injury. The functions that are associated with those structures or networks may be absent or impaired following an injury. And the field of neuroscience has learned a great deal about brain structures and their functions from studying patient populations with TBI. So a classic example that you may have heard of is Phineas Gage, who had a railroad spike that entered his eye socket and damaged his frontal lobe. And through his injury, we learned a lot about frontal lobe functions. So that's just an example of what we have learned from these unfortunate incidents. The physiological consequences of traumatic brain injury can also include diffuse axonal injury, which is abbreviated as DAI. DAI indicates that damage has occurred along axons, which are part of the brain cells. I have a depiction here just to remind you of your brain cell anatomy. So you have the brain, so you have the cell body, and then the axon, which connects brain cells to one another. And following injury, axonal transport impairment can occur, along with axonal swelling, which will lead to eventual axonal detachment. And that's often seen in DAI. There are also other consequences, such as secondary injury due to elevated ICP. So ICP stands for intracranial pressure. And after an initial injury, the intracranial pressure can increase due to brain swelling or expanded hematomas. This actually results in some secondary injury. So normal ICP is 0 to 10 millimeters of mercury. Pressures greater than 20 are considered abnormal. When they reach greater than 40, they're related to compromised cerebral circulation and neurological dysfunction. And then if we reach pressures beyond 60, those are typically fatal. And so we tend to see that, when the brain starts to swell, there isn't a lot of room for it to expand because of the skull. And if the pressure isn't monitored or reduced in some way, you can actually have pressure that puts too much pressure onto structures like the brainstem, which control breathing and heart rate. And so this is often a reason that people will pass away from a traumatic brain injury. So they will die from a traumatic brain injury because of elevated ICP that puts too much pressure on structures in the brain, like the brainstem. We also see a number of functional consequences of traumatic brain injury, which shouldn't be terribly surprising. Survivors of TBI are susceptible to the following. So physical deficits, these might include difficulties using their limbs, using their hands, difficulty in walking or balance, language limitations, either in understanding or producing language, social interaction difficulties, emotional problems. So there are regions of our brain that help us regulate our emotions. And if those regions get damaged, we often see people have a lot of difficulty managing their emotions, along with a number of cognitive deficits in areas like memory or attention. The multifold consequences of traumatic brain injury are still only partially characterized and understood, which can make assessment and treatment particularly challenging. This was certainly what I experienced as a clinician, and part of my role as a researcher is to try to better understand TBI so I can help improve assessment and treatment that occurs in clinical settings. We typically classify traumatic brain injury by severity. So as you learn more about traumatic brain injury, you will see these severity indicators used. So acutely, it's assessed using the Glasgow Coma Scale, the GSC, which evaluates eye, verbal, and motor responses to determine a score. I have the original citation of this. So this was actually developed in 1974. The eye response that is being assessed is associated with the following score. So if a person is not able to open their eyes, they get a score of 1. If they only open their eyes in response to painful stimuli, it's a score of 2. If they open their eye in response to speech, that is a score of 3. And if you see eyes opening spontaneously, like the way that you open your eyes as you wish to, that would be a score of 4. That's the highest score. So as you can see, higher scores indicate less impaired function. Similarly, for verbal response, score of 1 is no verbal response. A score of 2 is incomprehensible sounds, where you might see moaning but no words. Score of 3 is inappropriate words, such as random or exclamatory articulated speech but no conversational exchange. A score of 4 is confused. So the patient is responding to questions coherently, but there's some disorientation and confusion. And the score of 5 indicates that they're oriented and responding that way. And then finally, there's a motor response where there's a score of 1 where there's no motor response at all. A score of 2 where they're doing extension of joints to pain. A score of 3 indicates abnormal flexion to pain. And then a score of 4 is a more normal or a more typical response to pain, so flexion or withdrawal from pain. So if you were to put a painful stimulus towards the hand would flex inward to move away from the painful stimulus. A score of 5 indicates that they're localizing their movements towards the pain, and a score of 6, they're able to obey commands. So these are used to evaluate someone who has an acute injury. And as you can see, the scores here help us classify the TBI by its severity. So a total score less than 9 indicates a severe injury. A moderate is a total score. A moderate brain injury is one where someone receives a total score between 9 and 12. And if someone receives a total score between 13 and 15, that's typically considered a mild injury. I should note that there are some disagreements about the score categories and when these scores are most useful. So, for example, there's some conversation in those of us who study traumatic brain injury about when scores should be acquired and when they're most useful. Such as scores acquired in the emergency room or the emergency department may be better at classifying injury severity than those acquired in the field. So in the field indicating in the place where the injury happened. So for example, if someone has a car accident and they're unconscious after their car accident, they might get a really low score, but then they regain consciousness relatively quickly. And by the time they've reached the emergency department, their scores are much higher. So that might be a better indicator of what their long-term severity is going to look like. And that's a really helpful categorization that we use for helping to understand how quickly people are going to respond to therapy and what their outcomes might end up being. I'd like to share just a little bit now about the prevalence and the risk of traumatic brain injury. As you can see here, this information is from the CDC. So I have the hyperlink at the bottom of this slide that you could follow to get more information. So a few statistics that I wanted to share. So in the United States in 2019, there were over 223,000 TBI-related hospitalizations and over 64,000 related deaths. I realize that we are likely to have international viewers here, so I'm just using the data that are available to me in my home country, but I imagine that these prevalence rates are relatively similar in similarly sized countries or at a similar rate by capita. Older adults, so people who are over 75 years old, tend to have the highest rate of TBI-related hospitalizations and death. And males are nearly 2 times more likely to be hospitalized from TBI and about 3 times more likely to die than females. This is thought to be related to testosterone hormones and engagement in risky activities that individuals who produce high levels of testosterone, males, tend to engage in more risky activities. So a few causes and risk factors for traumatic brain injury. Again, this is from the CDC. So the most common causes of TBI include falls, firearm injuries, motor vehicle crashes, or assault. There are certain groups of people who are more at risk for TBI. These include racial and ethnic minorities, service members and veterans, people experiencing homelessness, people in correctional or detention facilities, survivors of intimate partner violence, and people in rural areas. The good news about all of this information that we find about traumatic brain injuries, and the majority of TBIs are mild in severity. So depending on where your information is coming from, this can be up to 80 to 89% of traumatic brain injuries that are sustained are considered mild in severity. So the descriptors I gave before and talking about all of the awful things that can happen after someone sustains a traumatic brain injury, they're actually quite a bit more rare than some of the milder injuries. And mild injuries include something like sports-related concussion, which is another area of research that I've been involved in. And there might be other presentations on sports-related concussion, so I won't get into that so much. But things like concussion are in that category of mild. And so a lot of people have had an experience of having a concussion. So they have had an experience of a TBI, but fortunately it was mild in severity. And for the most part, people can recover fully from mild injuries. All right, so just a brief summary on what I've shared so far. So TBI is damage to brain tissue as a result of an external force and is usually classified in terms of severity using the Glasgow Coma Scale. TBI can affect individual or connected brain structures, which are called networks, and that can result in various functional deficits. TBI is quite common in the United States, but the majority of TBIs are mild in severity. And researchers and clinicians often specialize in age focus, such as pediatric, or mechanism focus, like sports-related concussion, as I just mentioned, or severity focus. And they might be primarily working with people with moderate or severe. You might also see people working with veterans or survivors of intimate partner violence. And so there are likely to be additional presentations here at ENIGMA-U on these more specialized populations that are studied. So that is the end of my presentation. I want to thank you for your time and your interest in traumatic brain injury. I hope this was helpful for you.